Hello dear students, today we'll discuss in detail about the general anatomy of bones. We'll discuss about the various classifications of bones, then the ossification centers, the law of union of epiphysis, blood supply of bone and other important features. We all know that the study of bones or the science that is concerned with the study of bones is termed as osteology, where osteon means bone and logos means science. In an adult, you know that the skeletal system consists of about 206 bones, and we can divide the skeletal system into two parts, that is axial skeleton and appendicular skeleton. The axial skeleton, as the name suggests, it forms the axis of the body which supports and protects the organs of head, neck and trunk. So it consists of about 80 bones among the 206 bones, and it includes the skull, which includes cranium and face, then the auditory ossicles, that is the ingus, malleus and stapes, then hyoid bone in the center, then vertebral column, thoracic cage that includes the ribs and the sternum. The rest of the bones, that is the 126 bones, are forming the appendicular skeleton. So that includes the bones of upper limb, lower limb and the connecting bony girdles which anchor the appendages to the axial skeleton. So the bones of upper limb are humerus, ulna, radius and bones of the hand, whereas the bones of lower limb are femur, tibia, fibula and bones of the foot. Whereas shoulder girdle is formed by the scapula and clavicle, and the pelvic girdle is formed by hip bone that includes ilium, ischium and pubis. The synonyms of bone are os, that is a Latin word, or osteon, which is a Greek word. Bone is one of the harder structures of the body. It is a specialized connective tissue, or you can say it is highly vascular mineralized connective tissue which consists of cells and dense intercellular organic matrix impregnated with inorganic salts. The organic part, that is about 1/3 of the bone, is formed by collagen fibers which are responsible for the resilience, whereas the inorganic part, that is about 2/3, is formed by calcium salts which is responsible for the hardness and rigidity. Now let's see the functions of bone. So a bone forms a rigid framework. It acts as a surface for attachment of muscles, tendons and ligaments. It serves as levers for muscles for movement. It helps in the protection of viscera. It contains marrow, which is factory of blood cells. It acts as a storehouse of calcium and phosphorus. And the paranasal air sinuses affect the timbre of voice. Now let's see the various classifications of bone. We have already seen the classification based on the position, that is the axial skeleton and the appendicular skeleton. Now we have to see the classification based on shape, ossification or development, histology and maturity. Based on shape, you can divide bones as long bones, short bones, flat bones, irregular bones, pneumatic bones, sesamoid bones, accessory bones and heterotopic bones. A long bone has a shaft with two ends, and the ends are capped with articular cartilage. It has got a central medullary cavity, and long bones ossify in cartilage. And these are vertical bones which are meant for weight bearing, and they act as levers for muscles. I hope you can identify the various long bones shown here. So you can say it has long tubular bones, and these are humerus, radius and ulna, femur, tibia and fibula. Similar to long tubular bones, you also have got short tubular bones which are also known as miniature long bones. And the examples are metacarpals, metatarsals and phalanges. The peculiarity is that these bones are having only one epiphysis, or you can say it has got only one end. You have to remember this point in mind, that is the epiphysis of all metacarpals and metatarsals are directed towards the head, except the first metacarpal and metatarsal where they are directed towards the base. You can see here, so these are the heads of the different metatarsals and heads of the different metacarpals. And the epiphysis of all these metacarpals and metatarsals are directed towards the head, whereas the first, here you can see the first metatarsal and the first metacarpal. In both of these, the epiphysis is directed towards the base. The long bones are incomplete without knowing about the modified long bone. So the modified long bone is nothing but the main clavicle. So what is the peculiarity of the clavicle and why it is known as a modified long bone? This bone does not have medullary cavity. It ossifies in membrane unlike the other long bones which ossify in cartilage, and it lies horizontally unlike the other long bones which lie vertically. At this point you have to remember two things. Why clavicle is a modified long bone even if it is not fulfilling the criteria of a long bone? That is because functionally the clavicle is weight bearing and it transmits the weight of the upper limb to the axial bones. And you have to know one more example of a modified long bone, that is the body of vertebra, and that is also due to the same reason, that is it helps in the weight transmission. The short bones are typically cubical in shape and it presents 6 surfaces. Out of these, the 4 surfaces are articular, whereas the remaining 2 surfaces give attachment to the muscles, ligaments, and are pierced by blood vessels. So the examples are carpal and tarsal bones. All short bones ossify in cartilage after birth except 3 tarsal bones, that is the talus, calcaneum and cuboid bones, which start ossification in the intrauterine life. So keep in mind, because that can be asked as an MCQ question. That is, the 3 tarsal bones talus, calcaneum and cuboid ossifies in the intrauterine life itself, whereas all other tarsal bones and the carpal bones ossify after birth. Next is flat bones. Flat bones consist of 2 plates of compact bone with intervening spongy bone and marrow. And the examples are most of the bones in the vault of skull, the ribs, sternum and scapula. So in case of bones of vault of skull, the intervening spongy tissue is known as diplo, which contains numerous veins. Next set is irregular bones. As the name suggests, they are irregular in shape, and that include vertebrae, hip bone and bones at the base of skull. So they consist mainly of spongy bone and marrow with an outer covering of compact bone. Next is pneumatic bones. So you know that pneumo means air. So that means these bones are nothing but bones that contain air-filled spaces that are lined by mucous membrane. And these bones are confined in close proximity to the nasal cavity. And these include the frontal bone, maxilla, sphenoid bone and ethmoid bone, and corresponding to that you get the sinuses like frontal sinus, maxillary sinus, sphenoidal air sinus and ethmoidal air sinus. So what are the functions of pneumatic bones? The main function is that these bones make the skull light in weight. Otherwise you won't be able to carry the weight of your skull while you're walking. And the next function is it helps in the resonance of voice, or it helps in the resonance of the vibration of sound. And these act as air conditioning chambers by adding humidity and temperature to the inspired air so that the air becomes suitable for the purpose of the body. Next set is sesamoid bones. So sesame, that is an Arabic word that means seed. So these bones develop as seeds in the tendons of some muscles when these tendons are subjected to friction during the movements of joint. So you can see 2 figures here that shows one of the main examples, that is the patella, that is developed in the quadriceps femoris, and the other one is 2 bones beneath the head of first metatarsal in the flexor hallucis brevis. Some other sesamoid bones are pisiform bone in the flexor carpi ulnaris, then fibula, which is present in the lateral head of gastrocnemius muscle, and you can also get a sesamoid bone at the cuboid bone in peroneus longus. So what are the peculiarities or features of sesamoid bones? So you know that they develop in the tendon of muscles, They ossify after birth, and these are devoid of periosteum. So periosteum is the outer covering of bone. So these sesamoid bones are devoid of periosteum, and there is absence of Haversian system, that is the basic unit of bone, which is also known as the osteon or the Haversian system, is absent in case of sesamoid bones. So what are the functions of sesamoid bones? It helps to resist pressure, it helps to minimize friction and to alter the direction of pull of muscle, or it can act as pulleys for muscular contraction. The next set of bones include accessory bones. So accessory bones are also known as supernumerary bones, and these are not always present, and they may fail to unite with the main bony mass, and usually they are seen associated with the skull bones, that is the sutural bones, or also known as the Vermian bones, and sometimes they are seen between the parietal bones, that is the interparietal bone. So some other examples are os trigonum, that is related to the posterior tubercle of talus. Talus is a tarsal bone. And os vesalianum, that is related to the lateral surface of the base of fifth metatarsal bone. So these are also considered to be accessory bones. Next set is heterotopic bones. So this is abnormal growth of bone in the non-skeletal tissues, that is including the muscles, tendons or other soft tissue. So that means these bones are normally not present and they are formed by some injury or due to some musculoskeletal trauma. So one of the examples is the rider's bone, that is seen as a sesamoid bone in the tendon of adductor longus. And you can see here it is seen in riders, that is horse riders, where they use the adductor longus muscle, that is considered to be the horse riding muscle, and this muscle is helping in the adduction of thigh. So due to the continuous friction, due to the use of the adductor longus muscle, sesamoid bone develops in the tendon of adductor longus. So these are normally not present in that adult, but that later forms due to any musculoskeletal trauma. So because of that, it is known as heterotopic bones, and the example is rider's bone. We have seen the classification based on shape. Now let's revise some of these. The first A, you can see that is humerus, and that is a long bone or long tubular bone. B is corresponding to the carpal bones, so they are short bones. Now C is showing the sternum, that is that it is the flat bone. Then D is showing the vertebra, that vertebra is irregular bone. E is showing the patella is the sesamoid bone. So next classification is based on ossification or development, or you can say it is the bone formation. So according to that, you have got three sets, that is membranous bones, cartilaginous bones and membranocartilaginous bones. So in membranous bones, they are formed by intramembranous ossification, and the examples are bones of the vault of skull and the facial bones, whereas the cartilaginous bones are formed from the cartilage models, and they are bones of limbs, vertebral column and thoracic cage. Whereas membranocartilaginous bones ossify partly in the membrane and partly in cartilage, and that includes clavicle, mandible and temporal bone. Based on histology, you have two sets, that is the compact bone and spongy bone or cancellous bone. So you can say the bone mainly consists of the outer compact part and inner spongy part. The compact part is ivory-like and extremely porous, and that is dense, as the name suggests, and it forms the outer part of the bone. Whereas spongy bone, or you can say cancellous bone, as the name suggests, it is sponge-like meshwork consisting of many trabeculae, and within the meshwork there are many spaces which are continuous and occupied by marrow and blood vessels. Now these trabeculae are arranged along the lines of maximal internal stress, and they are adapted to resist stress and strain to which a bone is subjected. So since we have discussed about the growth structure, that is the compact bone and spongy bone, you also have to know about the periosteum. That is, each bone is covered by periosteum except at the articular surface. And you have already seen that the sesamoid bones don't have periosteum. And you know that the interior of the bone is formed by the medullary cavity, which consists of bone marrow, and these are lined by a vascular membrane that is known as the endosteum. Now the periosteum is of two layers, that is outer fibrous layer that is containing the collagen fibers, and inner cellular and vascular layer, which is also known as the osteogenic layers, and they contain, as the name suggests, they contain cells, that is osteoblasts, which deposit layers of bones on the outer surface of young bones. So those are the two layers of periosteum, that is the inner cellular and vascular and outer fibrous layer. Now, what are the functions of periosteum? You know that it covers the bone. So that means it protects the bone and it receives attachments of muscles, and also it maintains the shape or contour of the bone. And it gives nutrition to the outer part of the compact bone by periosteal vessels. And it also helps in subperiosteal deposits of bone formation, which increases the width of the bone. So these are the main functions of periosteum. Based on maturity, you can divide it as immature woven bone and mature or lamellar bone. So in the first figure, you can see the immature or woven bone that are irregularly arranged, and in the mature bone, you can see many lamella, concentric lamella, and that is forming the lamellar bone or the mature bone. Now let's see the parts of bone. So what are the main parts of bone? They include epiphysis, diaphysis and metaphysis. So epiphysis means ends of a bone. You can remember it like E, that is epiphysis, ends of bone. And the diaphysis is nothing but the shaft of bone. So the metaphysis is the joining area between the epiphysis and diaphysis. Metaphysis is very important because it is the most vascular part of the bone, because most of the supplying arteries and veins enter through this area. We will see more functions of the metaphysis in the coming slides. So you can identify the structure of a long bone in this figure. You can see basically you can see the outer compact bone and the inner spongy bone and the central medullary cavity. Now the ends are marked as the epiphysis, the shaft is marked as the diaphysis, and the joining area between the diaphysis and epiphysis is the metaphysis. Now we'll see the parts of young bone. So parts of young bone means you can see here there is epiphysis, metaphysis and diaphysis, and also you can see a growth plate. So the growth plate, or also you can say it as the epiphyseal plate or the epiphyseal cartilage, is nothing but a plate of hyaline cartilage that intervenes between the epiphysis and diaphysis of a growing bone. And as long as the bone grows in length, the epiphyseal cartilage persists. And when the full length is reached, that is, it reaches at about puberty, at this time the epiphyseal cartilage is replaced by bone. Now the ossification, that is the bone formation, begins earlier in females than in males, and later the fusion between the epiphysis and diaphysis is completed earlier in females than in males by about 2 to 3 years. So I hope you can understand the epiphyseal line or the epiphyseal cartilage that is seen between the diaphysis and the epiphysis. The epiphyseal growth plate has got 5 zones. They are zone of reserve cartilage, zone of proliferating cartilage, zone of mature and hypertrophied cartilage, zone of calcification of cartilage, and zone of ossification of cartilage. So now let's see the bone cavities. The marrow cavity and the spaces within the spongy bone contains bone marrow. And bone marrow is of two types, that is red bone marrow and yellow bone marrow. Red bone marrow is normally restricted to the spaces of spongy bone in the adult, whereas yellow marrow consists mostly of fat cells, and these marrow can revert to red marrow in case of extreme blood loss. So see in this diagram you can see the normal bone marrow transformation, and you can see in infants, that is less than 1 year, you have got the red bone marrow. Whereas in childhood, that is between 1 to 10 years, you can see the starting of the yellow bone marrow in the center. Whereas in adolescence, that is 10 to 20 years, mostly it is replaced by the yellow bone marrow. And in adults, you have mainly yellow marrow only, but in some places, that is the area that is related to the spongy bone, you have got red marrow. But you have to remember, in case of extreme blood loss, this yellow marrow can get reverted to the red marrow. So next you have to remember the ossification centers. So ossification means, I told you, that is the bone formation. So the ossification centers means the site where the bone formation begins. So these are of two types, that is primary ossification center and secondary ossification center. The primary center appears before birth, that is by about 7th to 12th week before birth. And the primary ossification centers starts at the shaft of long bones. Some exceptions are that is cuneiform and navicular, which are tarsal bones, and all carpal bones ossify after birth. So I have already mentioned when we discussed about the short bones that the three tarsal bones, that is the talus, calcaneum and cuboid, ossifies before birth. That means all these three tarsal bones ossify in the intrauterine life itself, that is by the primary ossification center. But other tarsal bones, that is other tarsal bones, are the cuneiform bones, that are medial, lateral and intermediate cuneiform bones, navicular bones, and all the 8 carpal bones. All these bones ossify after birth. Whereas the secondary ossification center appears after birth, that means from birth to approximately 5 years. And since the primary ossification center was in the shaft, here the secondary ossification center is present at the ends of long bone, that is at the epiphysis. Now here also you have got exceptions, that is the lower end of femur and the upper end of tibia, both of these ossify before birth. So all the secondary ossification centers which is seen at the ends of long bone appears after birth only, except the lower end of femur and upper end of tibia, which appear before birth. So both these sets of exceptions you have to keep in mind. So diaphysis is nothing but the shaft of bone that develops from the primary ossification center, and it develops before birth. Metaphysis, we have already seen, that is a joining area between the epiphysis and diaphysis, or you can say in other words, the end of diaphysis facing towards the epiphyseal cartilage is known as the metaphysis. And the bone grows in length at the expense of metaphysis. So this region is considered to be highly vascular. I have said this before because most of the supplying arteries and veins enter through this region. And this region has got profuse blood supply from nutrient arteries, periosteal arteries and juxta-epiphyseal arteries. And the peculiarity is that here the nutrient artery forms hairpin-like capillary loops, and microorganisms can settle within these bends, that is within the hairpin loops, and that can lead to infection of long bone. So infection of bone basically affects the metaphysis. And this region is considered to be the zone of active growth. So the epiphysis is the end of bone. Okay, so the epiphysis or the ends of bones are developed from the secondary ossification center, whereas diaphysis is developed from the primary ossification center. The epiphysis is classified into 4 types, that is pressure epiphysis, traction epiphysis, atavistic epiphysis and aberrant epiphysis. The pressure epiphysis helps in transmitting the body weight, and it protects the epiphyseal cartilage. It is covered by articular cartilage, and you can see in this diagram, it is the region of the long bone that forms the joint is the pressure epiphysis. Now examples of pressure epiphysis are head of femur and humerus, and the condyles of femur and tibia. So you know that through these region maximum weight is transmitted. So that is the example of pressure epiphysis. Next is traction epiphysis. So traction means what? It means pull. So these ends or epiphyses are formed by the pull of muscles, and they are non-articular. And you can see in this diagram, they provide attachment to muscles. So these are trochanters of femur and tubercles of humerus. And also you can say the mastoid process of skull. In case of mastoid process, the sternocleidomastoid muscle gets inserted to this region. When the baby is able to hold his or her head in the normal position, due to the pull by that, the mastoid process develops. So initially it is underdeveloped, later it develops by about 2 years of age. So that is also considered to be a traction epiphysis. So keep this point in mind, that is, in a bone where both pressure and traction epiphysis are present, the ossification center appears earlier in the pressure epiphysis than that of traction type. And also you have to remember, if the two ends are having the same epiphysis, that means if the two ends are having the pressure epiphysis, then the ossification center appears in the proximo-distal direction. So that means in case of, for example, in case of tibia, you have already said that the upper end of tibia you have the condyles, and the lower end, both the tibia upper end and lower end helps in the weight transmission. So both of them are having the pressure epiphysis. So ossification center appears in the proximo-distal direction when both the ends are having the same epiphysis. So that means the upper end will be ossified first, then the lower end. Whereas in case of the fibula, you can say the fibula upper end is having the traction epiphysis because of the pull of a muscle known as the biceps femoris muscle. The lower end helps in the weight transmission. So fibula, the upper end is having the traction epiphysis, whereas the lower end is having the pressure epiphysis. So according to what I said initially, if a bone is having pressure and traction epiphysis, the center appears earlier in the pressure epiphysis. That means in case of fibula, the center appears earlier in the lower end, whereas it appears later in the upper end. So next epiphysis is atavistic epiphysis. So basically it is an independent bone, and this bone acts as a parasite. So what will the parasite do? Parasite will grow on the host to acquire the nutrition from the host. So similarly, the independent bone fuses with the main bone to get its nutrition. So that is the atavistic epiphysis. An example is coracoid process of scapula, and also os trigonum, which is seen at the posterior tubercle of talus. So we have discussed this when we discussed about the accessory bone. So these two are the examples of atavistic epiphysis. Aberrant epiphysis is the fourth type, and that appears at the unusual end of a short long bone. And you know that short tubular or short long bone is the metacarpal bone. So you can see here in the head of first metacarpal bone, you get the aberrant epiphysis. So now we'll revise the various types of epiphysis. A, that is showing the head of femur. You know that head of femur helps in the weight transmission. So that is pressure epiphysis. Then B is denoting the trochanters of femur. So trochanters are formed by the pull of muscles. So that is traction epiphysis. C is showing the os trigonum as well as the coracoid process of scapula. So these are basically independent bone that grows onto the host for nutrition. So that is atavistic epiphysis. And D is showing the head of the first metacarpal bone, and that is aberrant epiphysis. You also have to remember about two other types of epiphysis, that is a simple and compound epiphysis. So sometimes more than one epiphysis can be seen at one end or both ends of a long bone. So when one epiphysis fuses with the diaphysis by separate epiphyseal plate, it is known as simple epiphysis. Whereas sometimes the multiple epiphyses initially fuse together and then unite with the diaphysis by one epiphyseal plate. That is known as the compound epiphysis. So the simple epiphysis is seen in the upper end of femur, whereas compound epiphysis is seen at the upper and lower ends of humerus. The growing end of long bone is very important, and this is defined as the end where the secondary center appears first but unites last with the diaphysis. That means since the epiphysis unites last with the diaphysis, that means it grows for a longer period before the union. So how will you identify the growing end of long bone? So you have got nutrient foramen that is seen along the middle of the shaft of long bones. This nutrient foramen is directed away from the growing end. So how will you remember that? You can see in the first figure, in the milking cow position, the arrows indicate the direction of the nutrient foramen. So you can remember by a cord that is, to the elbow I go and from the knee I flee. So you can see in the upper limb, the both arrows are directed towards the elbow. That means nutrient foramen is directed towards the elbow. So that means the growing end is the opposite region. Whereas in the lower limb, you can see the nutrient foramen are directed away from the knee. Since you know the nutrient foramen, can you identify the growing ends in the upper limb and lower limb? So in the upper limb, you can say the region of the shoulder and the wrist end are the growing ends, whereas lower extremity, the knee ends of the femur and the tibia and fibula. That means the lower end of femur and upper end of tibia and fibula are the growing ends. Now, what is the significance of the growing end? Any injury or any infection to this end in young age is significant because it makes the bone stunted in growth. So you have to know about the growing ends. An important law you have to remember is law of union of epiphysis or law of ossification. That means the secondary center of ossification which appear first are last to unite with the shaft. We have discussed that when we learned about the growing end. In the region where the secondary center appears first, these centers will be last to unite with the shaft, and vice versa. Where the centers appear last, it unites first. Usually the fusion of epiphysis with the diaphysis starts at the puberty and is completed by about 25 years of age. And you already know that the end of long bone where the epiphyseal fusion is delayed is known as the growing end of bone. Now this law is violated by fibula. Now we'll see why the fibula violates this law. Fibula has got a shaft, upper end and lower end. In the lower end, the ossification center appears by 1 to 2 years of age, whereas in the upper end, it appears by 3 to 4 years of age. So according to our law of union of epiphysis, we said that the secondary center that appears first fuses last with the diaphysis. So according to that, what should have happened? The lower end should have fused last. But see here, it fuses by 15 to 17 years, whereas the upper end is fusing by 17 to 19 years. That means there is violation of rule. That means even though the lower end, the ossification center appears earlier, it is earlier fusing with the diaphysis. Why this is happening? We have already said that in a bone where the pressure and traction epiphysis are there, the secondary center appears at the region of the pressure epiphysis, then at the region of the traction epiphysis. So I have already said that in fibula, in the lower end, you have pressure epiphysis because that is the region for weight transmission, whereas in the upper end, due to the attachment of the biceps femoris muscle, you have traction epiphysis. So actually, where will the secondary center appear? Initially at the region where you have the pressure epiphysis. So that means the secondary center appears initially in the lower end and later in the upper end. So the appearance of secondary center, that part is clear here. Then what will happen? Why the fusion has occurred earlier in lower end? You know that with the direction of the nutrient foramen, you know which is the growing end of the fibula. So which is the growing end of fibula? You know the nutrient foramen is directed away from the knee. So from the knee I flee. So since the nutrient foramen is directed away from the knee, that means the upper end of the fibula is the growing end in that region. So the growing end definitely has to fuse last with the diaphysis. So because of this factor, even though the lower end has appeared first, the upper end is the last to fuse. So you can say the law of union of epiphysis is violated in this case, especially it is violated by the lower end of fibula. Even though it appears first, it is even fusing earlier with the diaphysis. Now we'll see the blood supply of bone. So the bone is basically supplied by the periosteal arteries, the nutrient arteries, then the juxtaepiphyseal or the metaphyseal arteries and the epiphyseal arteries. So first we'll see the nutrient artery. Nutrient artery supplies the bone marrow, that is the medullary cavity, and the inner two-thirds of the cortex. That means the inner two-thirds of the compact part of the diaphysis. You can see here it grows in the periosteal bud and it enters at the middle of the shaft of the bone. So before piercing the bone, the artery has got a tortuosity that minimizes the blood pressure and also allows the movement of bone without affecting the nutrient artery. Within the bone, the artery divides into two branches and these branches are known as nutritiae, one for each end. Now after the division, these branches again divide into smaller parallel vessels and that enter the metaphysis. So after entering the metaphysis, they form hairpin loops. These loops in turn anastomose with the periosteal, juxtaepiphyseal and the epiphyseal arteries. So I have initially said that the metaphysis is the most vascular area of the long bone. That is because of this fact, because the hairpin loops that are formed in the metaphysis anastomose with all other set of arteries. Next set is periosteal artery. So numerous vessels ramify beneath the periosteum, as you can see in this figure, and they enter the Walkman's canal to supply the Haversian system in the outer one-third of the cortex or outer one-third of the compact part of the bone. Next set is epiphyseal artery. It supplies the epiphysis. So according to the mode of blood supply, it is divided into two types. That means the first type, in the first figure you can see the articular cartilage and the epiphyseal cartilage are continuous. For example, in the head of femur. So that means the artery pierces the epiphyseal cartilage and then enters or supplies the epiphysis. So in case of any injury in the epiphyseal cartilage or in the epiphyseal separation, that can lead to a vascular necrosis of the epiphysis, because if there is any injury in the epiphyseal cartilage, since the artery is piercing the cartilage and entering into the epiphysis, the blood supply to the epiphysis is cut off. So that can lead to a vascular necrosis of the epiphysis. Whereas in the second type, as you can see here, the articular cartilage and the epiphyseal cartilage are not continuous. So the blood vessels are entering the epiphysis directly without piercing the epiphyseal cartilage or the articular cartilage. So because of this, even if any injury to the epiphyseal cartilage occurs, there won't be a vascular necrosis of the epiphysis. So that is the significance of the epiphyseal arteries. So the last set is metaphyseal arteries. We have already seen that the nutrient artery divides into many branches and then later forms the hairpin loops in the metaphysis, where they are forming end arteries. So before epiphyseal fusion, you can see if the epiphyseal cartilage is there and epiphyseal fusion hasn't occurred, the hairpin loops act as end arteries and they do not anastomose with other arteries. But after the epiphyseal fusion, the end arteries are no longer there. That means the hairpin loop, these loops anastomose with other arteries like periosteal, juxtaepiphyseal and also the other nutrient arteries. So this figure will give you an idea about the metaphyseal arteries, that is before the epiphyseal fusion and after the epiphyseal fusion. In the upper end you can see the epiphyseal cartilage is there. So the hairpin loops are there and the metaphyseal arteries are not anastomosing with other arteries. Whereas in the lower end you can see the epiphyseal cartilage is not there and there is anastomosis between the metaphyseal arteries and other arteries. That means epiphyseal fusion has already occurred. So that means the metaphyseal arteries are free to anastomose the other arteries like the periosteal, juxtaepiphyseal and the epiphyseal arteries. Whereas in the upper end in this figure, since the epiphyseal cartilage is there, the further anastomosis is not occurring. Also, you have to remember that any injury to the region where the epiphyseal cartilage is there, that means where the epiphyseal fusion hasn't occurred, in that region any injury can predispose to stunted growth because the anastomosis hasn't occurred. between the hairpin loops and other arteries. So that can lead to stunted growth and also the avascular necrosis of the epiphysis. So that is the significance, especially in young children, since the epiphyseal fusion hasn't occurred in them, that can lead to the avascular necrosis and also stunted growth. The venous drainage of the bone is by veins, for example, basivertebral veins, and in compact bones, they accompany the arteries in the Walkman's canal and they run through the red marrow. The lymphatics also travel through the same route. The nerves accompany the blood vessels and they are mostly present at the articular ends of long bones and vertebrae, and they are also seen freely in the periosteum. So I said it accompanies the blood vessels, and so it enters through the nutrient foramen. And you can see the periosteum is rich in sensory nerves which are sensitive to tearing or tension. So you might have experienced hitting of your shin, that is the anterior surface of the tibia, over to any surface. So you might have experienced severe pain while hitting over the shin. So that is because it is the periosteum is more closely related to the skin, and since it is rich in sensory nerves, it is very sensitive to pain also. And most of the nerves are autonomous, that is they are both sympathetic and parasympathetic. So growth of a long bone, it grows in length and as well as in thickness. So it grows in length by multiplication of cells in the epiphyseal plate, whereas it increases in thickness by multiplication in the deeper layer of periosteum. You have to remember a condition known as osteomyelitis in children. So osteomyelitis means the inflammation of the bone, that is osteo, and myelo means bone marrow. So why this happens? We have already seen that there are many hairpin bends or hairpin loops in the metaphyseal vessels. So because of this hairpin loops, any injury occurs, the microorganisms can get easily into the blood, and since the hairpin loops are there, the bacteria gets trapped within the bends, and the blood flow in the bends will be sluggish blood flow. So that can predispose to infection, that is the osteomyelitis in children. The break in the continuity of bone is known as fracture. So it is of different types, that is simple, compound fractures, green stick fractures, comminuted fractures, impacted fractures, open fractures, segmental fractures, closed fractures, spiral fractures, and linear fractures. Bone marrow aspiration is a clinical procedure by which a small amount of bone marrow cells as well as a fluid is collected by a needle aspirated through the bone. Now the collected fluid and cells are observed for any disorders of RBC, WBC, and platelets. Now the next one is bone marrow biopsy, and that is done to diagnose spread of any cancer cells, and that will help in the treatment of cancers. Bone marrow transplant is the treatment by which you replace the unhealthy marrow with a healthy one through intravenous injection. I hope you have understood this topic. We'll come up with further topics in the coming sessions. Thank you.